11% in Forsyth County, anyway, which is where I looked at the numbers today. It depends a little bit on the day of the week, and but they are declining. This is all good news. One has to put into perspective a little bit, though, what positive tests, percentage of positive tests are. Is the number of tests that are positive divided by the number of total tests. So if you would go to a population that you would think would be very unlikely to have COVID, your percent positive test is going to be very low. If you go to a population that has a high chance of having COVID, which would be people with fevers, coughs, muscle aches from the higher impacted zip codes, then you're going to have percentages roughly around 10%, 11%. So it depends a little bit. It's interesting in our preoperative testing in our area from a lot of hospitals. And these are tests done of asymptomatic people before going to surgery. Our positive percentages is about 0.4, so well under 1%. So that would be a representation of a cross-section of a community. So that kind of gives you an idea a little bit about positive testing, positive percent testing. And so you have to take it a little bit in context. I would say here in the triad, we're probably more likely, especially right now, for reasons we'll talk about in a minute, I think we're more likely to be testing symptomatic people than asymptomatic people. And a lot of you who've wanted to get tests, I think, have run into that. Now, there's been a lot of stuff out in the last week and a half about masks and mask efficiency. So let's talk about masks for a minute. Masks work, and masks decrease transmission of COVID from a person to another person or the environment. In other words, they keep your respiratory goblets that might have virus in them if you're asymptomatic or pre-symptomatically infected. They keep them to yourself rather than into the world. So that's good. It takes an R0 of transmission of 2.5 people infected from one person well down below 1. If you get that R0 below 1, that means that transmission, if you could sustain that and if everyone did it, would eventually die out, which is a cool idea. So let's wear our masks. Not all masks are alike. The best masks have two layers of fabric, the cloth masks anyway. 2 layers of fabric, and then they cover your nose and your mouth, and they fit relatively tightly on your face so that the respiratory droplets can't get out around the edges of them. If they're below the nose, they don't work so well because your nose is not covered. If they're above the mouth, they're not going to work so well. There are a couple kinds of masks that don't work as well as the others. And one of them is the so-called neck gaiter, which looks kind of stylish and cool. It's usually worn down around the neck, and you pull it up over the face kind of like a railroad bandit from a bad Western. Those are very thin. People who wear them tell me they're comfortable, but unfortunately, because of the thinness of the fabric and the way they're designed, they don't really work. That was just proven by a study at Duke that got published this week. And so those are best avoided. The other mask, excuse me, that's best avoided is the kind that's got a valve on it. And that kind of mask is more of a mask that's designed for protecting yourself from paint and aerosols that are in the air, like in construction. What happens with that valve is when you breathe out, all of your respiratory droplets go out through the valve. So that doesn't work so well either. So let's avoid the vented mask, and let's avoid the gaiters. The other masks that you're going to see a little bit more of now are the clear masks. There's clear fabric masks and clear plastic masks. While I haven't seen any specific studies of those, because of the way they're designed, they should work. But they allow people to see your mouth. Well, that may not be useful for a lot of us, but for people who teach, particularly languages, or work with people with communication difficulties, including people who are deaf, or if you're trying to teach a child with dyslexia, then looking at the lips is very important. It's a very important part of the communication. So these masks can be used in those settings. A lot of stuff still coming out about children and COVID, and so I know we talked about it last week, but I just kind of want to summarize a little bit because there's another study that people have been asking me about. And so, early on we were talking about how kids weren't getting COVID as much, and early on in the pandemic they reflected less than 1% of all of our COVID cases. And now kids are about 10% of our COVID cases. And so what's different? Well, early on in the pandemic, most of us were sheltering at home, and so our kids were staying home and not getting out and about as much. And then the other aspect of it is that there were a lot of adults who still had to get out and about, people with essential jobs, and we had a lot of early on workplace-related outbreaks, like particularly meatpacking plants and so on and so forth, and then those adults proportionately represented a lot more of COVID than the kids would have, just because they're the ones who are getting exposed early on. Our epidemiology is a little bit different now, and it has been different over the summer. Rather than having these larger outbreaks and clusters relating to workplaces, our outbreaks now are more related to social gatherings, family get-togethers, and family units, and these would include parties and such. So, because of that, and because they're more household-related, kids are involved a little bit more. But still, the kids are still only 10% of our COVID cases, and so that it's still a relatively small proportion. So a study came out this week that was talked a lot about in the media, where 90,000 kids have been infected in the last month and a half, and so because there wasn't a lot of perspective put on that, and this was across the whole country, by the way, people I think started to think that something changed about the virus. It's attacking kids now, or maybe we just weren't seeing them early. No, it has to do with the proportions. So, if you have 1 million cases that occur in a month and a half, which is what happened, we've had 1 million cases in the country now. Then, if you take the proportion due to kids of 10%, it's still a small number. So, but it looks large if you publish it, but it's still proportionally small. So, that number in that study really didn't surprise me at all, and that's what I would have estimated it to be just by doing some simple math on a piece of paper, knowing what our total cases are. So kids do get COVID, and but when they get it, they don't get as sick. Particularly the younger kids do very, very well. Less than 1% of all of our hospitalizations in the country due to COVID have been in children, they do have a little bit, they are a little bit blessed in that setting. Can kids transmit COVID? They do. And the older the kid, the more they transmit like an adult. So older teenagers act like adults in a lot of other aspects anyway, at least maybe they want to, but but the older kids' epidemiology seems to be more like adult epidemiology as far as their capability of transmitting it. Younger kids under the age of 10, though, are different, and we're still trying to figure out exactly why. A lot of cool theories out there to explore, but they probably are about half as capable as transmitting as an adult. And some of that may just come down to they don't move as much air, so there's not as many respiratory droplets. So where do kids tend to transmit infection is in the household, and it's not thought to be as a major driver or even a minor driver of transmission in the community at large. So a little bit about the epidemiology with kids. There was a question that was asked earlier, and I'll talk a little bit when we get to that, about the multi-system inflammatory syndrome, which is a very rare condition in kids that can follow COVID, and we'll talk about that then. Tests. So testing remains, I think, our biggest problem with managing COVID, both for populations and for individuals. With that big surge of cases that occurred throughout the South, sucked up a lot of our testing reagent, and because in the last 20 years we've moved to regional, large laboratory, regional-based testing, these all responded to that portion of the pandemic in our country. And so all areas in the country suffered shortages of testing reagent. And because of that, and because of the large number of tests that we had to do here, even in North Carolina, that came from Florida and Texas, our turnaround time got real long. In fact, sometimes almost as long as 10 days. The average was, I think, 7. So that is getting better, okay? And some of it's because we have less tests being submitted from other states. The other reason is that some of the laboratories have added equipment and people to test more and faster. So I think the average turnaround time is declining now. And with our major contract labs, such as LabCorp and Quest, it's down to 2 to 4 days, depending on transit time to get the specimen to the lab. So that's a good sign, because contact tracing really loses its effectiveness after 72 hours. So we want to get those tests back quick. I think we're going to have intermittent shortages of testing reagents for a while yet, but I do see some slow improvement in that in the near future. Regarding contact tracing, so contact tracing is what happens when you get a positive case, and then public health calls that case and says, hey, we know you were positive, we see it in our lab report. Tell me about the people you're around, and then you contact the people that case was around. That's contact tracing. So because public health has to basically call people based on cell phone numbers usually, it's doing the contact training and tracing and the informing, and then getting the quarantine down requires the person to pick up the phone that they're calling. And public health is having some trouble getting people to answer the phone, and it's not all sinister. It's not all people trying to get out of quarantine, but a lot of it's just simply that people don't pick up the phone if they don't recognize the phone number, and I'm guilty of that. If I see something that I think is someone trying to sell me my extended car warranty, I'm probably not likely to pick up the phone. But if it's labeled as coming from your county or from a public health entity, answer the phone. It's going to help you more than anybody. So maybe we'll just want to tell the car warranty people no thanks for a little while, but answer our phones. A little bit about vaccines. Our vaccine development continues to be, I think, encouraging. And as I said last week, I'm cautiously optimistic about it, and cautiously optimistic is about the best you'll get out of an infectious disease doctor. So that's pretty good. And the vaccines seem to be, in the early studies, producing antibodies that neutralize the virus. And they seem to be safe in the early studies. Now, we need big studies now to prove that they actually work. And we need big studies to prove that they're actually safe in large numbers of people. It takes a lot of people to get in these vaccine studies to do this. The faster we can enroll people in these trials and get people the vaccine in order to find out the answers to these questions, the faster we will have a vaccine. And that's a good thing. So here at Wake Forest Baptist Health, we have now embarked and started our first vaccine trial with Moderna's vaccine, which is a messenger RNA vaccine. It's been mentioned in the media quite a bit. It's encouraging. Its early results look good. Two-shot series produced neutralizing antibodies in just pretty much everybody in the early studies. So now we have to do big ones. So if you're interested in being part of a vaccine trial, here's what you do. And I'm going to read these numbers out. And so get your pen and pencil. I'll give you a minute. Get a pen and pencil. Or get your phone out and type it in. Ready? Here's the phone number to call, 336-713-7888, or email COVID-19 vaccine study at wakehealth.edu. I'll say the last one again, COVID-19 vaccine study at wakehealth.edu. And we're going to add those contact info to our Facebook Live little information box that you can get with it. So you can have that. So if you're interested, contact, call or write and see. Now, they're going to ask you to answer a bunch of questions about yourself and about where you live and what you do. And then if you fall into a category that would qualify for the vaccine trial, then you'll get contacted back. And the reason why that's the case is because, for instance, the Moderna vaccine trial involves 30,000 people, and in order for the vaccine to get approved by the FDA, you need to enroll the right demographics of people. So you want a lot of women, you want a lot of men, you want a lot of young people, a lot of older people, people with underlying conditions, people who don't, so on and so forth. And you want them from areas where there's a fair amount of virus circulating. And so, doing a vaccine study in the middle of Wyoming, that's where you're 100 miles from the nearest person, doesn't make sense, because you can't see if the vaccine's going to work or not, because there's no virus around. So, the people in California running the trial, they're the ones who select the people. But if you want to be on a list to be considered, put your name in the hat. I would do it, and you can be part of a really cool thing to help us find a great vaccine to use. Which, if all goes well, hopefully we can start vaccinating people in late winter, early spring, after we've had some cases. So, with that, I think I'll go ahead and start the questions from people. So, Jill asks, are vaccine trials looking promising? Well, we just talked about that. I think they are. And then she goes on to ask, will there be protocols for who gets the vaccines first? Yes, there will be protocols about who gets the vaccine first. And so there's a lot of things to think about when you put protocols about how you prioritize vaccine. First thing is you want to give it to people where it works. So for instance, let's say the vaccine trial says that response in people over the age of 80 is like 20% because of age or other reasons. Then what you want to do is vaccinate the people around the 80-year-old and not the 80-year-old. Because vaccinating the 80-year-old is kind of futile. If it doesn't work, why give it to them? Okay? But you can vaccinate and form a protective cocoon in that household. So that's one example. Another example, who's more likely to be exposed to COVID? So, these are people who are out and about and are essential workers and where there's a lot of COVID, nursing home employees, people who work in prisons, hospital workers to some extent, and first responders, people like this. And so these are the factors that go into trying to figure out how to prioritize vaccine. There could be some geographic aspects to it, so prioritizing people in geographic areas where there's more active transmission and cases occurring than when there's less. And then you have to think about the whole global scale, because it's not just HIS in the United States, but it's all the other countries in the world. So it can get kind of complicated. Can you comment on the antigen test versus the PCR test for COVID, and when should each test be used? Is one test more accurate than the other? Sure. So you're going to see more antigen testing coming out because the readers and the kits for doing it are coming out now, slow but sure. And the antigen test can be done oftentimes as what's called a point-of-care test, which means it doesn't have to get sent anywhere. And it doesn't have to get sent to a large laboratory or to a large hospital. And technically, it could even be done in a doctor's office if they have the reader and the test kit. So it's kind of like that flu test that you get in the doctor's office. You go to the doctor's office, I got a sore throat. Okay, let me test you for strep, let me test you for flu, and then they come back 20 minutes later and tell you the result. That's almost always an antigen test done at the doctor's office. And we use antigen tests for flu, we use it for strep, and a lot. So now we have one for COVID. The PCR test actually looks, though, for RNA, the genetic material of the virus. That test is done on a nasal swab, where the antigen test is, or a nasopharyngeal swab usually, where the antigen test is done just from the nose. So the PCR is a little bit more sensitive than the antigen test. We don't know yet about how many false positives we'll get out of the antigen test. There'll probably be a few, but we'll know more about that in a month or so. But is that test good enough? Yes, in most cases it is. So if you have signs and symptoms compatible with COVID and the antigen test is positive, you got COVID. The problem comes a little bit more in using the antigen test for asymptomatic people. If you have signs and symptoms of COVID and for some reason the antigen test comes back negative, your doctor may then want to do a PCR test on you just to confirm it. And so you might find yourself in that situation. But for the most part, it's good enough. It's 80% sensitive. So for most people who have COVID and have a fair amount of virus around, it's going to find it. And then the answer comes back quick in an hour or so. So then you can start your isolation right away, and public health can start the contact tracing right away. And this will slow the transmission of COVID in a community. So I think it's a good thing. What are my thoughts on COVID spreading through air conditioning systems? So this gets back to the droplet versus aerosol for transmission of COVID. And while aerosol transmission may occur in some specific closed indoor settings, such as a bar where a lot of people are yelling and there's a lot of droplets going out in the air and the air is getting jostled around and things can't settle down. But otherwise in buildings and such, it really isn't airborne transmitted. And it's never been shown to be transmitted in air conditioning or heating ventilation systems. Now sometimes you can go out and with a big swab and swab around and you might find some messenger RNA of COVID in the system, but there has been, no one's been able to find replication competent or viable alive virus in the system, and there's been no epidemiologic data to suggest that it goes. And the Navy's a great place to look for this because you have closed ships and you have shared air conditioning between areas. And most of I think the Navy's data is all that it's all been droplet oriented and not airborne. So I don't really think it goes through ventilation systems, but I don't think you need to worry about it. Can you explain what you know about kids and MISC? So this is the multi-system inflammatory syndrome in children that we sometimes see following COVID. Jessica asks, my husband and I both have had mild cases last month. We have a 1-year-old and a 7-year-old that did not become symptomatic and were not tested. Are they at risk for having multi-system inflammatory syndrome in the future? I think in your case, Jessica, I think that the odds of your kids getting MIS is really, really low. And for the following reasons. One is that there's only been about 500 cases described across the country. It's pretty rare. And so, if you just a roll of the dice would say that it's just not going to happen. It's really rare. Also, it was a month or so ago, and most of the cases of multi-system inflammatory syndrome that we've seen in children have been in a range of 2 to 6 weeks, with most of those being actually in the first 2 weeks following COVID. Just based on time, I think it's pretty darn unlikely in your kids. Asymptomatic versus symptomatic, it seems like it can occur from both ends, maybe a little bit more on the symptomatic side, than asymptomatic. And then the age range for multi-system inflammatory syndrome, there's sort of kind of two presentations. One in older kids, that's more of multi-system inflammation that resembles that sometimes we see in adults. And then there's the younger age presentation, which looks like Kawasaki syndrome. So if you want to learn about Kawasaki syndrome, you can Google it. But it's a certain kind of inflammatory syndrome in young children, and the age range for that tends to be between 2 to 7. A little older than Kawasaki syndrome, but still it's in the younger kids. The good news is that most of the kids who get multi-system inflammatory syndrome, while the syndrome itself is it's serious, almost all those kids get hospitalized, and a third will end up in an ICU. The vast majority of them recover and do well after a week or two, and so I think that part of it's great. We want to see our kids do well when they get sick. What are the long-term consequences of contacting COVID, symptomatic or not? How likely what percent have long-term consequences? How do these long-term consequences compare with other common respiratory illnesses? For example, do other respiratory illnesses cause long-term lung damage? So this is a great question. There are, yes, respiratory viruses can cause long-term lung damage, and that includes unusual cases from influenza. It can occur from something called para-influenza, which is another respiratory virus. It can occur from RSV, which is another respiratory virus we can get, and from adenovirus. It's unusual for long-term lung damage from these, but it does happen. There are also other long-term consequences from other respiratory viruses, and this is not well understood, but kind of fatigue syndromes or where people just don't feel well after these, and for some period of time, weeks to months, occasionally years. This is also relatively uncommon. Do these things occur with COVID? Yes, it does seem that they do. The long-term lung damage, we're still sorting out, but there can be some, particularly from the more severe cases of COVID. How serious is that? Well, I think for a lot of people that long-term lung damage may not even be recognized because we have a lot of reserve in our lungs. And so in order to get symptoms of chronic lung disease, you have to knock out a fair amount of lung tissue. So if you knock out 10%, you're not even going to know it. But if you're an athlete, and let's say you're a wide receiver on a college team, and you happen to have some promise, and you get COVID, losing 10% of your lung function may take a bit of time off your 50-yard dash. And if you're going at the combine from the NFL, that might make a difference. So, it's just something to think about. There are other potential long-term consequences of COVID. There's been some information over the summer now about myocarditis following COVID, which is an inflammation in the heart, which can be found in people with, even sometimes with mild to moderate symptoms, but usually follows the more severe cases. So more to come on that, and this will be something that we need to be watching over the next few years, actually, to find out, are there long-term health consequences of COVID like they are from some of the other respiratory viruses? Judy asks if you contracted COVID, would the fact that you had taken the pneumonia shot help you with the recovery? Yes, it could. It could. Get the pneumonia shot if you're supposed to have the pneumonia shot for other reasons, and this is usually in people who are over the age of 50 to 60 or so, and talk to your doctor about getting it, or if you have underlying health problems, talk to your doctor about getting it. I think it's about 10%, 10 to 15% of COVID, maybe a little bit less than that. I just saw a study, I think, that said around 8 to 10% of people who get COVID and have respiratory involvement, like viral pneumonia from COVID, can go on to get a bacterial pneumonia immediately afterwards. And so a pneumonia shot will help prevent that. So get the pneumonia shot. If you're due for it, get the flu shot. Everyone needs a flu shot this year. Everybody. Anyone over the age of 6 months of age, get a flu shot. This year, more than ever, get a flu shot. And the flu shots are out now, by the way. You should start seeing signs that they're available. So talk to your doctor or look at your pharmacy. Get a flu shot. How are most hospitals treating COVID patients? What medications are they giving, and are they treating with plasma? So most patients who get hospitalized with COVID are going to get remdesivir. Most of them. There are some times when we can't give it because of the type of underlying medical problem might be associated with an adverse effect. But most people will get it. If you've had COVID symptoms for more than 10 days or so, remdesivir may not work as well. And it's because remdesivir kills the virus or slows viral replication, actually. And so if it gets in the way of viral replication, that by day 10, you don't have much viral replication going on anymore. In fact, by day 10, it's done. And so remdesivir is not going to really help you much then. So getting it early works better. And there are some drug trials going on right now with oral agents that appear to have activity against COVID in the early trials. So these potentially could be given at a doctor's office or called in and could be given for treatment or even prevention for families before the symptoms have gone on a long time. And those, I think, would hold some promise. The other thing we're doing for outpatients in the hospital is using steroids for people who have severe lung involvement, because a lot of that is from the inflammation and the immune response from our body and not necessarily from the virus. So we try to cool that down with steroids. And it seems to help, actually. It reduces the length of time in the ICU in studies, and it actually reduces deaths from the study in England. And so most hospitals are doing that. And my personal experience with it in our health system is I think it gets people out of the ICU faster. So I'm an advocate of that. Plasma for a while, our health system as well as others were using convalescent plasma, which is serum from people who've had COVID because it might have antibodies in it. And we were using that to treat people, thinking that it might neutralize the virus. Fairly large study on that, big randomized control trial that was well done, came out last 2 weeks ago. Unfortunately, in using it for people who have moderate to severe symptoms who are in the hospital, so it's mostly ICU patients who are in the hospital, it didn't really work that well. We don't know if it would work well for people who are in the early stages of their infection while there is still active viral replication, because the plasma would have an antibody. If the virus is out there replicating, the antibody attaches to the virus, it might work better. So it may be the reason why that study didn't show that it worked is because it was given after viral replication was mostly over. So we'll still see plasma being used in trials, but right now we're not using it in our ICU patients. How long can someone be asymptomatic? Well, if you're asymptomatically infected, you can be, it's usually a little bit longer than if you were symptomatically infected. But it's still less than 10 days. So if you had a positive COVID test and you're asymptomatic, after 10 days you can come out of isolation because you're not infectious anymore, unless you're immunocompromised for some reason. Could you compare face masks versus face shields or wearing both? Can the eyes be at risk for droplets entering the body? Face shields are more comfortable. Kids might wear better and would cover the entire face. So face shields don't work as well as a face mask because the virus can come down or get around them on the sides with exhalation. Masks work better, but face shields are better than nothing. And sometimes they're the only thing you can do because wearing a mask wouldn't be safe. There are some people who can't wear masks because of underlying lung problem. They can't get enough air, or severe cases of claustrophobia, so on and so forth. And so for those cases, face shields are a reasonable alternative, but still not as good as a mask. Other times when face shields are used is you might say an instruction like in a swimming lesson or something. Obviously you can't wear a mask in a swimming pool, and it's probably fine in that situation. And there may be some kids who just won't wear a mask or can't wear a mask where a face shield might be used as an alternative, but it's not as good as a mask. Mike asks, can you talk a little bit about dance classes for high school age students? What would those studios need to do in order to present a safe area for the teachers and students? Well, first, hi Mike. Second is, that's a pretty specific area and an interesting one because there's a lot of things about dance that you need to maybe modify the usual precautions that you would use. And one of those is that there's a lot of air movement, so I think dancers should be masked when they're dancing. Two is that if it's in a studio and there's more than one person in the studio, you're going to want to be separated. Three is that between dance classes, you're going to want to wipe down and disinfect the horizontal surfaces in the studio, which doesn't take too long. Four is that hand hygiene is important. So dancers' hand hygiene going in the studio, dancers' hand hygiene going out of the studio. If you're doing one routine, you hand hygiene before that routine. When you go on to the next routine, you hand hygiene between them. And so you mix hand hygiene with what you're doing. And then lastly, the studio itself, where you're dancing, it may not be necessarily as much risk as the areas around the studio. So where are the dancers changing? And so locker rooms or fitting rooms are an area where there's going to be a higher risk of transmission. They're usually small. There's a lot of people in there and a lot of jostling and such going on. So dancers probably should come to the studio in their outfit and leave in their outfit rather than changing there. And then also other areas in the dance studio are going to have to be cleaned often, restrooms, bathrooms, so on and so forth. Break rooms and places where kids might socialize are going to have to be looked over after to make sure that people are personally distancing and wearing their masks while in there. Now, I think if you do all those things, it's safe to return to dance. But those would be things that I would think about doing. Not that I'm a dancer, by the way. I don't even play one on TV. All right, so can you please explain why it's safe, this is from Sarah, for school children to play in band class when they return in-person learning? Our school insists this is, and I want my child to play. I just can't figure out how it's okay. I did a lot of thinking about band for colleges in our area and also for high schools in our area when we were thinking about coming back for school. And there's a lot of things about band that are different. One is there's a lot of movement of air with wind instruments. And while a brass instrument, technically, the air doesn't come out the end of the brass instrument really so much. It's a vibration within the brass instrument. There's a lot of spit accumulation in the brass instrument, and that spit is expelled, and by most band players it's expelled either on the floor or into a cup in the area, and that spit, if that person has virus in them, there's going to be a lot of virus in that spit. And so band is a higher risk activity. The other wind instruments, clarinets, flutes, so on and so forth, there you have a lot of wind going out, and when you're expelling a lot of air, the more air expelled, the more respiratory particles, and if there's virus in those particles, the more virus out in the world. So I think band is a higher risk activity in schools. And how can you mitigate that risk? Well, do it outside. Have people 12 feet apart when they're playing, so marching band with large spreads for the people are safer than not, but doing inside, I'd probably just avoid it. I think it's too risky. Now, string instruments are a little different. You don't have all the air movement, so violins, cellos, so string ensembles and things like this, I think you can still do. Vocal, what about chorus and singing? Those are areas also that if you're going to do it, you're going to need to do it in a distanced way, and people are going to have to be masked. And unfortunately, masking changes the vocal characteristics of the notes and such, so a lot of choruses have just said it's not worth it unless you want to go outside. But even then, it just doesn't sound the same. So unfortunately, those are activities, I think, that are more difficult to do. I wish it wasn't so, but it is. So with that, we got through the questions. Kind of a long briefing this morning, but I'll open it up to my buddies and friends out there who've got cameras on me from the stations, and if they have any questions.
Dr. Ulrich, a couple questions. Football, it's on everyone's mind right now. Yesterday, North Carolina pushed all their sports into next year for spring football, so we won't have high school football. What are your thoughts on all that? And the ACC, which Wake Forest is part of, is still planning on playing football this year. What are your thoughts on how we're going to get through having some sort of football this year?
Yeah, I get asked a lot about football, and I'll put it out there. I like a good game of football. I'm a fan, but I tell you, I don't really see any way to play football with the current state of the pandemic in the U.S. And even if it got a lot better, I think it's going to be difficult. I mean, football's a contact sport. We've been having problems with cases in college football teams already. There's probably not one that hasn't been touched by COVID, by the way. And if they say they haven't been, I'm not sure that they're telling you the right answer. And you know, this is just going to happen. And so when you get football, people who have COVID in football, you're going to have the infected person or persons, and then you're also going to have people quarantined who happen to train around that person. So you're going to lose fairly large segments of your team. And how are you going to play like that? If you're a quarterback and you have no offensive line, it seems a little scary to me. And so I just think the logistics are going to be so hard to do it. And you know, there have been two, you know, was it the Pac-10 and I think in the Big Ten now, right? Pac-12 and the Big Ten have said, hey, you know, we're not doing it, and you know, stand by, maybe in the spring, but we're not doing it now. And then will the ACC come along? I think they probably will, but you know, there's a lot of things for them to think about. It's not all just about COVID, but I think, and again, remember what I said earlier. If you're a player and you get COVID and you lose 10% of your lung function, hey, yeah, you may be able to function throughout your whole life, fine. But is that going to take time off your combine? Is that something you want to live with? Do you want to give up a year of eligibility for that? So there's some decisions to be made at the player level and the family level too. And then also, you know, the primary mission of our universities is to teach and learn. So if sports get in the way of that, anyway. Now for high school, so high schools have put off their sports into November. You know, maybe a little bit of wishful thinking, things will be better then. I doubt they will be. It may be just kicking the can down the road. And then there's the whole other part. If we're not opening our schools, why are we having high school sports? Yeah, it's just a little bit of irony to me. So I think that's where we're sitting right now.
And another thing that's come out this week is that the myocarditis, the NCAA it's become a big issue with that for athletes who apparently catch the COVID.
Yeah,
what is that?
Yeah, so myocarditis following COVID, we touched on it earlier. Myocarditis is an inflammation in the heart that is associated with COVID. We don't totally understand it real well, but it may be related to teeny, tiny little blood clots that sometimes can form in COVID. So if it happens in your heart, it causes a little bit of inflammation around them. And why all of a sudden are people thinking about it, worried about it? Well, a couple of reasons. One, there was 2 studies out of Germany looking at people who recovered for COVID who were totally fine and had all their symptoms had resolved. Hey, you know, I'm fine. And they did scans on their hearts, MRI scanning on their hearts, and they found low-grade myocarditis in these people. They were asymptomatic with it. And so far, these people haven't had complications such as heart attacks or rhythm problems in their hearts. But you know, it's an open question: could that happen? And so, for athletes who are putting a lot of stress on their hearts, you know, high heart rates with large stroke volumes of the heart's working hard. And so, if you have a heart that's a little bit stressed out and you're making it work real hard, could it flip an abnormal rhythm? We call that sudden death. It's not a good thing. And so that's one thing that's been thought about, because, you know, the sports medicine people have been saying, following your recovery from COVID, you're good to go. You know, your cardio exercise and everything you want to do, you can do just like you did before. And I think they're rethinking that a tad bit now. The other thing is that, you know, there was the pitcher, I forget what team he was on, who developed post-COVID myocarditis and now is out for the season. So was it the Marlins, I think? Yeah. So anyway, so that's why people are talking about it. And it's a real entity, and I think it needs to be thought about seriously. Yeah. Any other questions? All right, I think that's all I have to say about that.